Today, we will be discussing chronic obstructive pulmonary disease, or COPD. COPD is a group of diseases characterized by persistent chronic inflammation with persistent respiratory symptoms and airflow limitation, which is not fully reversible. It includes chronic bronchitis and emphysema. The most significant risk factor for developing COPD is tobacco smoking, which accounts for approximately 70 to 80% of all cases. However, 25 to 40% of patients with COPD have never smoked. For those who have not smoked, environmental and occupational factors, such as those who are farmers, coal miners, construction workers, and those who have chronic upper respiratory illnesses as children, are at higher risk. The genetic factor which can cause early COPD, specifically emphysema, is called alpha-1 antitrypsin deficiency. COPD remains a major health issue, with greater than 384 million affected worldwide, which is 11.7% of the global population as of 2010, and it is the third leading cause of death in the world. Although chronic bronchitis and emphysema often co-occur, they affect the lungs in different ways. Chronic bronchitis involves three key factors: fibrosis of bronchioles, inflammatory inflammation, and remodeling of small airways. Mucus glands enlarge and increase in number, producing excessive mucus. This mucus will line and narrow the airways and plug the small bronchioles, which will prevent air exchange and increase airflow resistance. Clinically, this explains why patients will develop a productive cough with sputum. In emphysema, chronic irritant exposure causes destruction of the alveolar walls, which causes the lungs to lose their elastic recoil. Without this recoil, small airways will collapse during exhalation, trapping air inside. Over time, this causes hyperinflation, flattening of the diaphragm, and increased work of breathing, which is why patients with emphysema progressively become more short of breath. Next, we will discuss some of the symptoms and physical exam findings. One of the hallmark symptoms of COPD is a chronic cough, which is usually the earliest symptom. Also, we see sputum production, worsening shortness of breath on exertion, chest tightness, and fatigue. Some physical exam findings indicate the presence of airflow obstruction. As these patients develop hyperinflation, percussion becomes hyperresonant, demonstrating air trapping. In more advanced disease or in exacerbations, pursed lip breathing, accessory muscle use, and cyanosis become more common as patients work much harder to exchange air and maintain proper ventilation. On the next slide, we'll talk about some of the difference between chronic bronchitis and emphysema specifically. This image demonstrates some of the structural changes and physical exam findings that may be seen in our two types of COPD. We can think of our emphysema patients as our pink puffers, typically presenting with shortness of breath. These patients may also have a thin body habitus. Chronic bronchitis patients are called our blue bloaters, commonly presenting with significant smoking history, often overweight, with productive cough and sputum. These patients will more commonly have rhonchi and wheezing due to mucus lining the airways. Chronic bronchitis patients are also more likely to have peripheral edema due to cor pulmonale, or right heart failure. This will cause the right heart to work harder to pump, resulting in fluid backing up to the lower body. Again, remember, it's common for patients to have a mixture of both symptoms and signs. The diagnosis of COPD relies on a combination of history of exposures, symptoms and physical exam, pulmonary function testing, and at times chest imaging. Symptoms of shortness of breath or productive cough with sputum must be present, lasting at least 3 months per year for 2 consecutive years. Our gold standard for diagnosis is spirometry. After administering a bronchodilator, an FEV1 to FVC ratio of less than 0.7 confirms the obstruction of airflow. This distinguishes COPD from other diseases such as asthma. Additional testing may include arterial blood gas, chest x-rays, or chest CTs. Once COPD is diagnosed, patients are staged using the GOLD criteria. This considers symptom burden using the MMRC or CAT questionnaire, which is symptoms, history of exacerbations, and spirometry findings. We'll discuss those on the next slide. The image on the left demonstrates the spirometry finding of COPD. We can see that during a normal respiratory cycle, there's consistent flow throughout. In COPD, there is an obstruction of flow, which we can see demonstrated by the image. On the right, the GOLD assessment tool is demonstrated. It is graded as GOLD 1 through 4, and this is depending on the patient's post-bronchodilator FEV1 FVC percentage. Exacerbation history and symptom scoring is then used to place patients in one of the 3 categories, A, B, or E. Treatment is based on what category patients will fall into. This image demonstrates the progressive destruction and hyperinflation which can occur as COPD advances, as seen on chest x-ray. On the next slide, we're going to discuss some of our treatment options. The single most effective treatment for COPD is smoking cessation. Patients with COPD are also more likely to be immunocompromised. Vaccinations are recommended: the flu, pneumonia, and COVID-19. Pulmonary rehabilitation is another essential component of management because it helps to improve exercise tolerance, reduce shortness of breath, and improve quality of life long term. Pharmacologic therapy is tailored to disease severity. All patients with COPD should receive a SABA as a rescue inhaler, one of the most common being albuterol. They work as bronchodilators to open up the airways, which allows for more air to move through for better ventilation. Other maintenance therapy is indicated below. We will talk more about choice of therapy on the next slide. Once diagnosed, treatment is individualized based on the GOLD classification the patient falls into. Management is primarily focused on symptom burden and history of exacerbations. The mild group reflects Group A, which includes patients with few symptoms and low risk of exacerbations. Treatment begins with a single bronchodilator and a LABA or LAMA for symptom control. Maintenance. Group B patients are treated with dual long-acting bronchodilator therapy using the combination of a LAMA and a LABA. Finally, as the disease progresses, patients are treated with triple therapy, which includes the addition of an inhaled corticosteroid. Throughout all stages, patients should always have access to a rescue inhaler, which is our short-acting bronchodilator, such as albuterol. Studies have shown that patients with COPD are equally or more likely to develop long COVID symptoms. These patients experience significant improvements after participating in cardiopulmonary rehabilitation programs that combine aerobic exercise, strength training, and respiratory muscle training, improve exercise tolerance, reduce shortness of breath, enhance quality of life, and demonstrate improvements in pulmonary function testing, specifically diffusion capacity. These findings reinforce that pulmonary rehabilitation remains one of the most valuable non-pharmacologic therapies available for COPD patients, alongside smoking cessation. COPD is a progressive disease, but does not have to define a patient's life. With early recognition, diagnosis, smoking cessation, and rehabilitation programs and medical-directed therapy, we can help patients breathe easier, stay active, and improve their quality of life. Thank you for your time.